Asthma is a complex disorder characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. The interaction of these features determines the clinical manifestations and the severity of asthma and the response to treatment. The working definition of asthma is a chronic inflammatory disorder of the airways in which many cells or cellular elements play a role in, particularly mast cells, eosinophils, neutrophils, T lymphocytes, macrophages, and epithelial cells. In susceptible individuals, the inflammation causes recurrent episodes of coughing, particularly at night or early in the morning, wheezing, breathlessness, and chest tightness. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. So some causes of asthma will be the development of asthma appears to involve the interplay between host factors and environmental exposures that occur at crucial time in the development of the immune system. A definitive cause of the inflammatory process leading to asthma has not yet been established. So one is innate immunity, and another is genetics that play a role, and then the last one is environmental factors. So it's important to understand the difference between the role of short-term and long-term medications for asthma. Long-term control medications prevent symptoms often by reducing inflammation. They must be taken daily. So you can take one that's a 24-hour one, or you can take one that's 12 hours, so you'll take it once in the morning and once at night. And then quick relief medications, short-acting beta agonists, relax airway muscles to provide prompt relief of symptoms. Do not expect them to provide long-term asthma control. Using a short-acting beta agonist greater than 2 days a week indicates the need for starting or increasing long-term control medications. So you can put both of those together. All right, so some directions for taking an MDI. So you have your inhaler, and you're gonna get it started by taking the medication out. You're gonna roll it, get the medicine kind of heated up, moving around. You can shake it. You'll put it in the container again, and you'll put it in the boot. And then if it's a new one or it hasn't been used in a while, you want to actuate it a couple times and prime it. And then so you're gonna have it in front of your mouth, about 1 to 2 inches away. And you're gonna just breathe out normally, and then you're gonna put it in your mouth, making a tight seal in between your teeth with your lips, and you're gonna actually start breathing in slowly. So when you're breathing in, you're gonna press down while you're already breathing in, and you're gonna keep breathing in slow and deep, not fast, but slow and deep to get a good medication delivery. And then when you breathe that in, you want to hold that for 10 seconds, the medication, and then breathe it out. And then that's one puff right there for an MDI. And then for children, they'll use a spacer. And I actually recommend that for anyone that uses MDI because you get better aerosol or particle delivery from the medication. So dry powder inhaler for greater than 4 years old. You want to have a rapid, deep inhalation. So this is equal to, a rapid, deep inhalation is equal to a 60 liters per minute or 1 to 2 second inhalation. Minimally effective inspiratory flow is device dependent. Most children less than 4 years of age may not generate sufficient inspiratory flow to activate the inhaler. A therapeutic issue that will be commonly seen is the dose is lost if the patient exhales through the device after actuating. So you'll actually breathe in and then just kind of take the device away so you don't breathe back out. And on an MDI, just like I explained, greater than 5 years old, they don't have to have a spacer. Less than 5 years old, we like them to have a spacer just because we don't want them to waste the medication. Actuating during a slow, deep inhalation followed by a 10-second breath hold. Some therapeutic issues may include slow inhalation, and coordination of the actuation during inhalation may be difficult, particularly in young children and elderly. Patients may incorrectly stop inhalation at the actuation. So a breath-actuated MDI for greater than 5 years old, you're still going to have a tight seal around the mouthpiece, slightly more rapid inhalation than a standard MDI. So you're going to breathe in just a little bit faster, followed by a 10-second breath hold still. It may be particularly useful for patients unable to coordinate inhalation and actuation. Nebulizers can be used for any age of patient population. This is where the medication will be aerosolized in small particles through a mask or mouthpiece, and this will require the patient to just have slow tidal breathing with occasional deep breaths. And they can have a face mask or mouthpiece while doing this. A big therapeutic issue is bacteria infections can be transmitted if not cleaned properly. So identifying and avoiding environmental exposures, allergens and irritants and tobacco smoke are the main ones. For self-monitoring, assess level of the asthma control, monitor symptoms, and if prescribed PEF measures, recognize early signs and symptoms of worsening asthma, and then develop and review an action plan, take daily actions to control asthma, adjust medication in response to signs of worsening asthma,